Thank you, Dr. Klaus. Ladies and gentlemen, the NAS procedure is an excellent operative technique for the repair of pectus excavatum. We have done this operation for more than 1,000 cases since 1998. The median age of recent cases was 15 years old. However, in the first 100 cases, the average operation was 7 years old. As you know, there are pros and cons regarding the early repair of pectus excavatum in children. Negative opinions regarding the NAS procedure for children are risk of recurrence, chest wall constriction during growth, painful procedure, and serious complications, such as the risk of cardiac injury. This slide shows a case of chest wall constriction. He underwent the operation at 5 years old, and he came back to me at 16 years old. There is a constriction and the fibrosis around the bar. On the other hand, there are advantages of the early repair of pectus excavatum. The operation is relatively easy because of elastic chest wall. And post-operative recovery is quick, and operative complication rate has been reported low. And psychosocial effect and cardiopulmonary recovery can be expected in these cases. This slide shows our recent study on pulmonary function, patient VC after bar removal. Red bar is the cases of operated on 10 years old or less, and the blue bar is more than 10 years old at the time of the NAS procedure. In all cases, this is pre-bar removal, and 1 month after removal and 1 year after removal. In all stages, the younger children cases showed high patient VC compared to the older cases. And after 1 year removal, bar removal, the younger cases showed the patient VC showed more than 100%. So I thought that pulmonary function is that recovery of pulmonary function was prominent in cases who underwent the NAS procedure less than 10 years old. I was wondering that there will be a new surgical strategy for the young children with symptomatic pectus excavatum, which is the procedure should not be causing recurrence and chest wall constriction. This is the answer of my the new novel technology. The main technical point is to use an external brace, which is placed in the subcutaneous tissue on the ribs. The depressed chest wall is pulled up to an external brace using a non-absorbable sutures. A Duchamp needle with the stitch was used to pass the tip of the behind the costa cartridge, and a cutting needle was used to pass the stitch through the lower end of the sternum. Bilateral edge of the brace was fixed securely with the ribs to prevent shifting and flipping. This technique requires no mediastinal dissection like NAS procedure. There is no risk of cardiac injury. There will be no chest wall constriction while children grow, and the post-operative pain is minimum. These photos show preoperative and post-operative view with this technique. 2 centimeter midline incision and bilateral 1 centimeter incision are made, and an external brace was introduced in the subcutaneous tissue. 4 stitches on the center, and bilaterally, 2 stitches were made. From January 2017 to, July 2017 to January 2018, we have performed this operation in 8 children. The median age was 6 years old. Average Hara index was 4.5. Average correction index was 41. And average operation time was 81.3 minutes. We studied the change of the sternum vertebral distance before and after the operation, 3 months after the operation. Average sternum vertebral distance, pre-operative distance, was 44. And after 3 months, it improved to 65. This is the photo of the preoperative and post-operative view of the children. A child with the there will be an opposing view of this new technique. We have no long-term observation. And there will be risk of suture breakdown and risk of tissue invasion by the suture. However, in this, I have 6 months follow-up. And this procedure is safe and effective for children and less invasive than NAS procedure. And the short-term results are excellent. I have to look for those children for a long time. Thank you very much for your attention.